yes. Stephanie?
I assume so, but it's not.
I will be asleep, but okay. That's what the group wants. Y'all gonna be asleep again, shopping on Amazon, watching movies?
All the time.
I'm turning off every light but.
Oh, yeah.
I can do that. I bet y'all could. How's that?
That's great.
Yeah, if y'all are like, please turn the lights off so we can go to sleep, not listen to you. Okay, so, yes, this will be on exam 4. So this is, I want to tell you major concepts. Like when you're looking at the Davis Drug Guide, do not get tangled off in the weeds and give me every sign and symptom and like big major concepts that apply to these drugs as a whole. What are some common ones? Because one of our activities in just a little bit, we're literally going to spitball every drug that you've covered in clinical and let you tell me a little bit about it just from a brain dump. And then to surprise you how much you guys actually already know. And then pharmacokinetics wise, what are the only 2 things I really care about pharmacokinetics?
Whatever reaction is.
Huh? Yes, drug-to-drug interactions and one more thing. Not an allergic reaction, even before that. How do your kidney, or how do you, well, hint. So how do your drugs work? Where's it gonna go in, liver or kidney? You need to know that because if you have a renal failure or liver failure patient, obviously we need to choose different routes. And then we're gonna practice some NCLEX style questions and get you ready to go there. So these are our major drug classes that we're gonna go over. Yes, there certainly have been some other ones when you do your independent study part of this module. You'll find some other drugs, but we're gonna focus on the things that you give commonly at clinical, because that's the ones that you're gonna be tested on for these boards. Speaking of boards, let me go ahead and do my advertisement plug for the LPN. I would strongly encourage you to get your LPN, whether you actually work as one or not, because you know that life happens. And I would hate for you to, for whatever reason, go to semester 4, money runs out, you need to suddenly move cross country, you get deployed, whatever happens, I want you to be able to have a lock-in point so that when you return to a nursing program, you can do what they call the bridge, kind of your segue, just refresher to put everything back on your brain classroom style. And then you do those 2 RN semesters, you're out. It's a 1 year, so it's just a great thing to do. And it's also, if you can financially go for it, it's a good preview of what the NCLEX RN is gonna look like. You sat through that one, you can sit through the next one next time, sweat-free. It's just gonna be higher level question. So it's just good practice and good thing to lock in. And regardless of whether you take the board, please fill out the thing that Ms. Brooks will send to you. It'll be a little form and it'll go on our Canvas page. You fill out to have it stamped on your transcript that you were successful and you completed 114, 115, because that's something that nobody can take from you. So whether you do the board or not, that's independent of you, but do get the stamp. Take the time to fill that paperwork out so you can get the stamp on that transcript for that. Okay, moving on. So those are your classes. Now, there are prototypes highlighted in green. The only reason I say prototype, and it does not have to be your prototype. Just pick your favorite for that class and know drugs that are in that family kind of work like this drug instead of learning every specific drug. So for example, in the respiratory drugs, there's gonna be some antihistamines. Instead of knowing Zyrtec and Allegra and all, just pick one. They're all, for the most part, gonna have things in common and how they function in the body. So you can use one or not. So antihypertensives, if you can say your ABCDs, but plus E, you have all of your classes that we care about for this semester. So you have 2 A's, so your ACE inhibitors. What are those? Where do they work? What's that fancy thing you learned at the very beginning of fluid and electrolytes?
And, what is that?
The kidneys with the renin and the,
Yeah.
what's that? RAS.
Yeah.
That's where they work. So if ACEs don't work, guess what? That's when you can go to that other class, your ARBs, because they work on a different part of the RAS chain. And so that's why we like those. They're gonna work on RAS. All right? Then B for beta blockers. We're gonna do some highlights there in just a second. So beta blockers are going to work on the conductivity of those beta 2s and sometimes beta 1s. depending on the drug itself, but it works on those cells instead of in the RAS system. Then you've got your calcium channel blockers. Where do you have calcium channels? You're mouthing it, but say it.
Your heart?
Well, not only your heart, where else? Calcium channels.
Muscles.
Muscles. So we're going to work by relaxing smooth muscle. And so you can imagine the other types of side effects you may get if you relax smooth muscle. So helping there. But for your calcium channel blockers, the main concern is that relaxation. And then diuretics, we're gonna have a whole entire slide on diuretics. That works on your water balance, is how those will work. And so that helps jog to your brain what it might do and how they work. And then last one's gonna be your ED drugs or your vasodilators. And so we'll look at some safety things dealing with those. But if you can say your ABCDEs, you've got all your antihypertensives. But the focus of this slide, where they work. So your ACEs and ARBs work on the RAS system. Beta blockers on your beta cells. And then calcium channel blockers relax smooth muscle. Diuretics is on your water balance, so kidneys drive those. And your EDs or your vasodilators in your nitrate family. So let's look at some pearls or some overall views. If you have not looked at RAS in a while, let's hit the highlight reel there. But that's why we need to know RAS so we can know which drug and where it's operating. So first part, your renin. Who made your renin? Detected that blood pressure was low. Kidneys. Then it turns into what? Angiotensinogen, and then we have a 1 and 2 and all those things. But yes, then it's going to create our 3 A's, which really should have a little small superscript 3 up there for our 3 A's. Does anybody remember our 3 A's? One's in the pituitary. Which one's that? Who? Pituitary. Diuretic hormone. That one's up there in the pituitary. Then, that's your ADH. Yep, the antidiuretic hormone. Then you have, which one's made by your adrenal glands? That's on top of the kidneys. It's a steroid-based one. Loves sodium. Aldosterone. And then your last one's the angiotensin 2. And that one's gonna tell our blood vessels to squeeze, that smooth muscle to squeeze, and to get that pressure up. It decreases the vascular space. And then that gets your blood pressure up. Been a minute since that one, so review the RAS system, make sure you've got that floating in your brain. All right, ACE, those are your side effects. So if you remember ACE, there's your acronym again. So ACE is for your angioedema. So what is angioedema? It is your cardiac, and it's usually this upper portion, so intrathoracic pressure. They're going to have JVD, shortness of breath, just acute fluid overload there. A dry cough won't kill them, but it's annoying. But dry cough would be a sign. And then you're going to have your E for elevated potassium, so hyperkalemia. And ACEs are contraindicated in pregnancy. Got those. And then B for beat the betas. So you remember all your B's, that'll help you there. So if you scramble or rearrange, if you have any in clinical, I told you this, if you scramble up betas, what's the spell? Beta and beat, right? Scramble the letters. So what's your most concerning thing to do before you give somebody a beta blocker? Heart rate greater than 60. And then just a nice general, what you gonna do before you give your patient a blood pressure medicine? Check their blood pressure. I mean, that's that you would think, but the NCLEX probably gonna ask you something that simple. So these would be contraindicated in patients that already have existing bradycardia or heart blocks. And you'll talk about heart blocks, what those are in 114. But if my patient has a history of a heart block or has an active heart block, do not give them a beta blocker because you'll just make that rhythm worse. Bronchospasms, so these are contraindicated in asthma patients because they can help encourage your patient to have a bronchospasm. Remember that they can decrease your hypoglycemia or decrease your blood sugar, make the patient hypoglycemic, and can even mask those symptoms. So really watch your patients for hypoglycemia. And then again, if you remembered heart blocks, just anything where your patient's heart doesn't work well, you don't want to slow it down. The don't stop the beat section, easy enough. You're just going to teach your patients not to cold turkey these medicines, because they're going to wind up with either rebound tachycardia, rebound hypertension. Not going to be good for them. And sometimes, depending on their history, can even put them at stroke level. The calcium channel blockers come to mind for that class, but any of them, you just would not want to stop them cold turkey. Calcium changes, so if you have them on a calcium channel blocker, they are prone for orthostatic hypotension. So just a good rule of thumb with any blood pressure medicine, but specifically calcium channel blockers, you're going to have your patients change positions slowly and make sure that they don't have a feeling of dizziness before they begin ambulating. They're going to be constipated for whatever reason you would think with it relaxing, but remember, calcium in the GI tract is very hardening, makes stones, so you want to push fiber and fluid hydration for there. And then because of that extra blood flow getting to their brain, some will say that it causes flushing and headaches. And then just a nice little enrichment. Most of your patients that are being placed on blood pressure medicines will also be placed on some other things because of science and how heart history works in the body. So we would also put them on a statin, which treats their what? Cholesterol and triglycerides. And then aspirin, because we're worried about them having clots. If they're having, think about hypertension, if my blood vessels are tight and close together, I'm more prone to clot, so they're more prone for strokes, MIs, DVTs, things of that nature. So they'll put them on a quote-unquote baby aspirin and may upgrade them to the full-fledged 325 aspirin later. And then of course, so obviously if your patient has you have a question, your patient has a significant heart history and has been recently started on hypertension medication, what would the nurse anticipate to be additional medicines added to the care plan? Statins, blood thinners, things of that nature. And then, so what are the signs and symptoms the nurse may monitor for on the next question? All the things starting with statins, which you know by now, leg cramps and rhabdo. And then if you put them on coagulation therapy, looking for signs of free bleeding, GI bleeding, bruises, that sort of thing. And that, quick, fast, and hurry is your hypertension pearls. Questions on hypertension meds? Hello, that's kind of the easy one. And then I'll get a little more and more as you go. Notice those are major ideas. Those are not anything nitpicky specific to a drug. Just get some general rules in your brain. What? Making sure. All right, diuretics. So we have 3 in this class. Your thiazides, where do they work? And don't tell me with potassium or in the kidneys. They work on another channel. What's their favorite electrolyte for thiazides? Who's your main one for water balance? Sodium. There you go. So your thiazides work on the sodium channels. And then your loops and potassium sparingins work on the opposite sides of potassium. So loops you lose, and then spironolactone, it passes by. So we're going to retain it. So big overall rules there. Potassium sparing doesn't spare the side effects. So our typically male patients are the ones that are most likely not wanting to take this drug class because it causes a lot of sexual side effects, decreased T, gynecomastia, but most of those things will be reversible if they stop taking the medication. So if they do need to take it temporarily, but on a long-term basis, you may not be able to have your male patients take this one. Kidney stress, so remember that any diuretic makes your kidneys work harder because it's making your body process or filter more fluid. So you need to watch your kidney function. I would expect their function to go up slightly when using diuretic therapy, but if it gets into injury levels, then we need to report that and stop. So for example, if your patient routinely has a creatinine of 1, and I put them on furosemide, I'm okay with the 1.2, 1.3 because I know I'm making their kidney work more to filter that fluid. But if it has a big jump where we go like 1.8, 2, 2.5, our diuretics are punching our kidneys out, we might need to hold them or find a different way to diurese our patient. You'll see the same thing with the GFR. You'll see that GFR go up a little bit. That's good, but if it doubles 2.5 times, we gotta cut it. Always when you're worried about fluid balance, don't forget about your strict eyes, nose, and heavy weights. That's your best accuracy of your patient's fluid status. Potassium, I gotta remember my note here. So how each class does their, so if they're on a loop diuretic, what would your patient need to do? If they're on a loop for their potassium. So well, give me some foods for potassium.
Leafy greens.
I love it.
Banana.
That BOP, remember BOP, we're on BOP our potassium. Bananas, oranges, potatoes, because those were our cheap 3. Like those. But what if your patient's on spironolactone? You're gonna limit those foods. Now, don't say never and always. Nursing loves that limit. So you limit potassium. Or you would increase or supplement if they were on a loop, something like that. Potassium administration, if you don't remember those rules and regs, you might have to give potassium with this group. What about if you take potassium by mouth? What do we know about potassium by mouth? Yes, it is going to eat their GI system up. So we got to watch them for GI bleed and GI upset if they do potassium by mouth. Then the same thing in the vein. It's still aggressive, but what's it going to do there? Almost slow push. Slow push, they dead. Pump only. That is one of your cues. Pump only. And then it's gonna watch them for extravasation and things like severe irritating. You remember they say it burns. It's a vesicant. So monitor your IV, make sure it's in place. You may have to dilute it down or triple dilute it down because it is a vesicant. Potassium's aggressive. So we like it to support nutritionally when possible, but you just give the replacement if need be. And then lastly is if your patients are on thiazides, they might have a problem if they are allergic to sulfa. So we just won't even take the chance because just statistically, if they have sulfa allergy, thiazides will set that off. So that's your big ones there. Cruising. All right, respiratory. SpongeBob, he's struggling. All right, I heard you laugh, Caroline. That made me laugh. So several classes here. This is ones that may not be as familiar or given as common on med-surg floors. So you have antihistamines. We have a first generation, second generation. We don't like the first generation. What you know about Benadryl compared to Claritin? Why might I like Claritin more than Benadryl? I like the non-drowsiness of it. That's good.
Dehydration.
Very dehydrating. So in your old people, you will dry them up if you give them Benadryl. They're already dry. So making it nice and simple, your first generations come with a lot of undesirable side effects, where your second generations typically don't have a whole lot. So if your patient's itchy or having a runny nose, hives, things like that, let's shoot for a second generation, like your Claritin, Zyrtec, and Allegra. Those would be better options there for you. But yes, your first generations do come with drowsiness, drying, and also can cause some extrapyramidal symptoms, but we'll do that next semester in the psych. Decongestants, pseudoephedrine, Sudafed. What that one is. What you know about that one? Anybody ever have? Who can't get Sudafed, or what kind of patients love Sudafed?
Crackheads.
Yes, because what does Sudafed do to them? What does meth do?
Extra speed.
Gives you speed, right? And that's what it. So who are some patients we don't want them to have speed?
ADHD.
Well, potentially, but if they're taking something for ADHD, if they're already on a stimulant, I don't need to double up their stimulants. I like that.
Geriatric.
Two.
older.
Potentially, because stimulants are drying. I don't know if anybody takes that. It gives you dry mouth. Yes, the ding, ding, ding. That's my big population right here. Heart patients. If they have a history of hypertension, notice how a lot of your decongestants will say Sudafed free or phenylephrine free, because your blood pressure patients do not need this class of decongestant. So rather than it's not necessarily a decongestant, but we use it for one. What's a good over-the-counter one? It's the little blue and white tab, 600 milligrams. Used to have the little germ guy that you would get this stuff. Mucinex. Or guafenicin. Yep, guafenicin. But that's not technically a decongestant, but we use it as a decongestant a lot. That would be a better class of drug for your heart patients. So decongestants, no heart patients for our Sudafed. I think that's it. They're drying and stimulating. So people may report, obviously, if they're a stimulant, that they're going to have insomnia, things like that. But your bronchodilators, we're going to end in Turol. So you pick your favorite one. And that's your beta-2 adrenergics, if you want the fancy term for those. But they're going to bronchodilate exactly that. And we're going to look at our big side effect in just a second, but you already know what's your big side effect with beta-2s? Bronchospasms. So I got to watch for that. Or really anything that's inhaled, but specifically bronchodilators. Then you have your cholinergic blockers or your anticholinergics, depending on how you want to word that. This is going to be your stuff like that's in your duodenum, but they end in troprium. And they work on drying secretions up. So cholinergic makes things wet, so an anticholinergic is going to dry it up. So if you have dry asthma, I want this one. But if I have wet asthma where I'm occluded due to mucus or mast cells, putting a bunch of secretions out in there, fluid collection, I would want my anticholinergics. Your leukotriene modifier is going to be your maintenance medicine for your respiratory conditions like asthma or COPD, because they're going to help decrease the amount of those mast cells and help them from being so angry and responsive to anything that gets into that airway. And then we have to remember that oxygen is a drug too, so if it's prescribed up to a certain level, it's a drug, and there's some side effects there. We can change patients' ABGs if we give or administer too much oxygen. So the big takeaways for these classes would be if you have to give a bunch of respiratory agents, start with your bronchodilators first so that you can increase the size of the airway and get the other medicines down in there. You would think that would be counterintuitive, but I'd like to point that out. So bronchodilators would go first so your other agents can reach down in there. Most of these respiratory agents, especially when in a nebulizer, are going to create your fight or flight response. And so anything that you would feel like if I just suddenly scared you, or you see those blue lights in your rearview mirror like I do sometimes, you're worried it's you, you're going to have tachycardia, palpitations, anxious, jumpy, that sort of thing.
Every time I see him, it's always me.
Yeah, always you. We'll send them Sam's way. We talked about the anticholinergics already dry. So you'll see in that nurse in the making bundle when I refer to it later that they can't see, can't pee, can't spit, can't poop. You can actually can't spit, can't, but I can't put that on my PowerPoint slide, but it helps you rhyme. Can't see, can't pee, can't spit, can't. Okay, got it. And then your last one without the bronchospasm is you're gonna rinse your mouthpieces, your apparatus, your nebulizers, your whatnot, because you know all that gunk's gonna build up. It can cause thrush and secondary infections. So just when in doubt, clean it out. Just keep everything nice and clean and enclosed as possible so they don't wind up with secondary problems. And then, let's see, what's happening with microbials? Yeah, this will be our last one and we'll take a little brain break and then come back. So antimicrobials, notice I did not give you a favorite here. It's more about the acronyms because they change all the time. You get different ones, so we're just gonna go more about the class. So penicillin, simple enough. Cephalosporin, penicillins, let's rewind there. So when you think of penicillins, what are some treatment modalities that kind of matter, diseases that we're gonna treat there? All right, like that one. So we're gonna say upper airway. Penicillins are great for some upper airway things, like that. Cephalosporins, got your ceph. Where have y'all seen those the most? What floors? 6 and 7. What happens on 6? Surgeries. This is good for your gut bacteria. So if they have open abdominal surgeries, GY surgeries, GU surgeries, they got cut on, opened up, we like those for general surgery purposes. And then I heard some skin, and yes, you may see K-Flex for some skin infections, things like that. Tetracyclines though, your doxycycline, monocycline. If you haven't seen that one, this one is excellent for skin and tissue infections. This is your cellulitis, osteomyelitis, things like that. In addition to your next group, your mycins, your big hitters. Vancomycin, I love that one. So what body parts are you worried about with vancomycin? Your kidneys, and then one if I give it too fast, just like Lasix. Ears and kidneys, ototoxicity with your mycins. And then also with your mycins, there's another special rule. What you gonna check after every 3 doses? Peaks and troughs. We're gonna check those to make sure that our renal function is good and that our drug is effective. You may have to change your dosing. Last group, fluoroquinolones, your fluoxetins. These are good for lower respiratory, so your pneumonias and just all the junk in the bottom. And then you'll see these for UTIs sometimes also. But what's your fun fact about fluoroquinolones? It's gonna chop off this tendon.
Your Achilles.
Tendon rupture, very common with your fluoroquinolones. And then another fun fact is they will make older people psycho. Like they will make bless you. Grandma was already having difficulty, or has a sudden mood change, and we just started her on Levaquin yesterday. She's probably having a reaction to that fluoroquinolone. Antivirals, straightforward, so I'm not going to rehash those. Mr. Riccardi taught a lot of antivirals with his content, and so refer back to those. And then antifungals, the most common you're going to give is that miconazole powder into the skin folds, or a topical miconazole to like toenails for a fungal infection of the toenail, something like that is your most often used there. So all of that good antibiotic teaching is going to come back here on the next one. So our first concern is, hint, hint, be a pro with biotics. So probiotics, you're gonna, you know that it kills off good and bad bacteria. So we need to monitor for secondary infections. Those are your most common. So thrush in the mouth, yeast in the vagina, C. diff in the rectum. And so this can either be supplemented through nutrition, your favorite fermented food, or just add the probiotic pill to their routine. Lots of antibiotics result in GI upset, and so if that's the case, then administer it with food to decrease the dyspepsia. If you have a blood culture ordered and medications ordered, please, please, please grab your cultures first, because if you start antibiotic therapy, you're going to kill off the bacteria that quick, and we will not be able to detect what it was. And in a perfect world, I would love for you to get the culture and the results back and just do symptom management until the culture's back, and then treat the specific bug. Because we could sit here and talk about if, antibiotic resistance, being good stewards with antibiotics. There might even be a question about if your patient was diagnosed with flu, should your patient take the antibiotic? Because they might initially order antibiotics when the patient comes in. You get the culture, you get the nose swab, and what they call the torch, which is the nose swab thing. and the blood cultures and sputum cultures and all that stuff, and comes back, it's flu, what's the nurse's next action?
Take them off antibiotics.
Yes, why? Because flu is a virus, and so, and antibiotics only work on bacteria, so it'll be different. Then your good education, take them until they're gone. Don't stop it once you feel better. Don't, if you forget a dose, take it as soon as you remember it. Don't skip it. All those sorts of things, because failure to do so results in resistant bacteria. So the antibiotic will not be as effective the next time, or it may be that the bacteria figures out the pattern and it just doesn't work at all. And then plan B, so if you're on antibiotics, know that that can alter contraceptives. And so their patients need to have a second line of contraceptive while they're on antibiotics, because they can null and void it. And so that would be an unfortunate pregnancy window if they were not expecting it. And then lastly, a lot of them, specifically the tetracyclines and the fluoroquinolones, but just in general, there are some others that your patients become photosensitive and are easier to sunburn while taking antibiotics. So make sure to teach them about sun exposure, sunblock, wearing long sleeves, sunglasses, all those sorts of things, because they become photosensitive. With that, I've got 5:33. I'll see you back at 5:45.